Good afternoon, everybody. It's a great pleasure to be here, and thank you for the organising team for asking me. I know it's the last lecture of the conference, so I'll try and keep it up to time as much as I can. As Nick said, conservative management of high-grade disease has popped up throughout the meeting, and certainly it was quite clear in my region that it was happening, so we thought we'd do something about it. So, as I said, I work in the east of England. We're a fairly large catchment area. We have 8 reporting cytology units at 355,000 samples, and we see just over 20,000 women in colposcopy each year. I'm a lead colposcopist at one of the hospitals in my region, and we see 800 abnormal cases in my particular hospital. That aside, I'm exactly the same as you. I do exactly the same job as you. We cross-cover our colposcopy service, so although there's only 3 of us, the little Mr. Myron in the middle and Gemma, our nurse colposcopist, on the side, we cross-cover, so I do at least one colposcopy clinic every week. We've tried to keep it to a fairly small, tight-knit team, but I do exactly the same job as everybody else here in the room. So why did we think we need to do it? So it was quite clear from our visits that we were visiting units, and it was an increasing trend, I suppose, in about the last 2 years, and we began to discuss it at our 6-monthly regional meetings. And it seemed to be raised in 2 main ways, which was people were coming to us very concerned, saying, well, I've sort of done a biopsy on somebody which has got high-grade disease. I've then done a LETS, and there's no CIN in the LETS. I'm worried that I've overtreated them. Or, increasingly, over that 2-year period, it seemed to be true conservative management where a biopsy had confirmed high-grade disease and people within their unit had said, I'm not going to treat this lady, I'm going to treat it conservatively. So the best thing we thought we could do is actually talk about it informally at our regional meeting. So I must stress this is not badged Public Health England advice. It's what we, as the East of England, the 18 colposcopy units, came up with us amongst ourselves. So I don't want anybody to think this is in any way, shape or form official advice, because it isn't. So, what are we actually aiming to do? What did I want to do with that? So I want you to take your head out of the clinical bit for a minute and put it into the governance world in which I've lived, being a quality assurance director and a lead colposcopist in the past. I want you to try and think of the talk from a protective point of view. What I'm trying to do to all my lead colposcopists is to actually give them some form of guidance and protection for managing these ladies. John had talked about there was a BSCCP audit of CIN2, and it's quite clear that actually a lot of people are managing, would certainly offer people conservative management, be that selective or all. The aim was not to produce a guideline, but really to give you guidance, and I wanted that to be protective for everybody. We did actually include CIN3, but for, I think, pretty obvious reasons, I would hope we excluded CGIN and actual invasion. I don't expect you to be able to read this, but that's the actual letter that went out, so it's sort of proof from the meeting in December where we actually agreed what these should be. And the initial part of that is actually the get out of jail clause. So current treatment is LETS. Okay, so I think the most important thing to say is anybody who starts to manage somebody conservatively with high-grade CIN is skiing off-piste. Okay, so you are going off-piste, so it's about making sure that you've actually got some form of protective mechanism behind you. So as we said there, it may be considered on an individual basis, following informed consent and discussion with their colposcopist, and we'll expand on that a little bit as we go through. So good practice point 1 we decided was to take each patient on an individual basis. The potential conservative management of high-grade CIN is likely to be more suitable for some patients than others. We thought that age, the degree of abnormality, and the fertility status was likely to be the 3 key determinants. So as I said, we'd included CIN3, which is why we thought they were. Interestingly, in the national audit of CIN2, when people were asked what were their main determinants factor, it was age, HPV status, immunocompromise, and the size of a large lesion. I would have been interested to know what their thoughts were on CIN3, but my gut feeling is that it would probably be the same as ours. It would be age, fertility, and the degree of abnormality that was present. Good practice point number 2, all patients should have multiple directed biopsies performed to grade the level of the high-grade lesion, and most importantly, to exclude invasive disease. I think you've absolutely got to exclude invasive disease. So in line with document 20, we agreed on multiple biopsies. Our third point was, as a general principle, conservative management may be more suitable for women with CIN2 than CIN3, but this is not preclusive. I didn't want to say to somebody that they should potentially not treat somebody with CIN3. Certainly in my unit, as I've said there, we did actually have one patient who had CIN3. She was advised to have a loop. She adamantly said that she didn't want to have a loop, so I wanted to reflect that in the guidance as well. But certainly in our region, I think most people are pretty uncomfortable treating people conservatively with CIN3, and I would suspect that's probably the gut feeling in the room here today, and certainly over the last 2 days at conference when I've been discussing it with people. This, I think, is the most crucial bit. All patients should be discussed at the MDT meeting, where the department can agree a consensus for treatment. They should be discussed at the first MDT applicable following their referral to colposcopy and their biopsies having been performed. This allows a timely review of both the cytology, histology, and an agreed management plan. I think this is actually the most crucial bit, and I think what tallies on from that from a clinical governance and from a quality assurance point of view is actually how good you then document that MDT decision, but then also how you document your findings, your discussions, your pros and cons with the patient. And I would suggest you probably, in this group of patients, need to be a little bit more diligent, and I use that word very sparingly, a little bit more diligent than you might need to do. I also think you should probably discuss them at each visit. If you're going to manage somebody conservatively, I think you should probably, to protect yourselves, do that at each visit, so it is an MDT decision at each particular visit. Practice point number 5, this is all about how you then manage these patients afterwards. So patients with high-grade CIN who are being treated conservatively, we agreed should be seen on a 6-monthly basis within the confines of colposcopy, using both cytology and colposcopy to follow them up, and discharge to community would be dependent upon everything returning to normal or definitive treatment having taken place. And that was certainly the findings from the National CIN2 audit, was actually that most people felt that a 6-monthly staying in colposcopy was the way to go. It's actually small numbers of patients. So I've looked at my own unit, and we've tried to not sort of embrace it, but we've tried to use these guidance in applicable cases. And there's only actually 6 patients in my unit at present who are doing it. So this isn't actually a large cohort of patients. It's not a large number of patients, but I think it's quite an important group that we may have potentially not managed as well as we could in the past, and perhaps have a better way of doing it now. Good practice point number 6 is that these clinical practice points are not applicable to CGIN. I mean, we were quite categoric that CGIN is a completely different entity and should be managed completely differently. I would also suggest that patients who are sent to you with a cytology suspecting invasion, or colposcopy, which has got a very, very obvious invasive lesion, you shouldn't be guided by your sat-nav that says drive off the end of the cliff when clearly the cliff is in front of you. So I would urge caution in those referral points. So I'm going to put my money where my mouth is and try and make it a little bit more interesting, and I'm actually going to just talk you through one of our ladies, and I want you to approach it from a quality assurance point of view, okay? I'm going to show you some slides and some histology and some colposcopy. Don't so much concentrate on those, but concentrate on what's written in the letters and what's written in the MDT outcomes and stuff. I've tinkered it ever so slightly for confidentiality reasons, but obviously there is no patient identifiable information. So this is a young woman who was referred to us last year in February, was her first screening invite. She was referred with moderate dyskaryosis. She's never had a pregnancy. She's using the oral contraceptive pill and is thankfully a non-smoker. And actually in her consultation, she specifically raised concerns about treating on her fertility. So she was seen within 4 weeks, she was seen in March, and her colposcopy suggested CIN2, and she had multiple punch biopsies that confirmed CIN2. So This is actually me. I'll put my hand up and say it's actually me. I'm quite happy to name and shame. So I took a decision when I was first appointed as a consultant 8 years ago that I would write to my patients in person. I've done that in every single clinic. I do that in gynecology clinic, colposcopy clinic. I write an individual letter to each patient, and the general practitioner is copied into that. Now, occasionally, I do write an additional separate letter to the GP, but I've always thought from my governance point of view, I know what I've told the patient knows what I've told the patient knows what the GP knows what the patients know, and everybody knows what everybody knows. For me, it just seems the most sensible thing to do. We all do that in private practice, so I don't see any good reason why we shouldn't do it in our NHS practice as well. So that's the decision that I've taken. And as you can see there, I've highlighted very clearly that she's brought up the wishes about and her concerns about fertility, and that's why I've taken multiple punch biopsies and not done a see and treat. So again, she then gets an individualised letter. So we've taken her biopsies, and these biopsies have confirmed abnormal cells grade as CIN2, and then I'm going to tell her that you're going to go to our colposcopy cytology MDT meeting. So the MDT review, so we've tried to move with the modern world. We do a monthly MDT meeting, not every 6 weeks. It's jobbed planned for all. That was the most painful process of all, I can assure you, okay, for the for the gynecologists in the room. Actually trying to get everybody job planned to go to the meeting, I think caused more stress than anything else put together. And we do an actual visual review of both the cytology, we do a full review of the colposcopy digitally, and then we also review the histology. As much as possible, we get the presenting, each case is presented by the colposcopist who's seen them, and we do have a DISIS system, so this does allow us to actually, not quite real time, but actually review all the cases in which we've used DISIS as part of the MDT. The outcome is sent to the patient and the GP, and it's the responsibility of the chair of the meeting to inform the patient and the GP of what's happened. So we would give her history, and then the first thing that we'd say is cytology. I'm really rubbish at all cytology, as you'll find out in the MDT stuff, but I think most people can say that there's some slightly darker bits in the middle. Yeah? Yeah? Good. You've got about as much knowledge as me then, so that's perfect. So that was felt to be, and there's a repeat of one of the same slides, on cytology review, is still felt to be moderate dyskaryosis. As I said, we've got a DISIS system, so not all patients currently will have a DISIS examination, but if you've seen the new funky DISIS Ultra, there's no reason with the adaptation of the machine, from now on, all our patients will have a DISIS colposcopy. This allows you to review the whole colposcopy as part of the MDT review with the map. You can digitally archive and allow longitudinal tracking. But for me, it actually makes the MDT decision dynamic. It's not looking at one image in time. It's actually looking at how this acetowhite develops over a period of time, reducing error, and most importantly, it beats the usual rubbish artwork. So I will name and shame myself, as you can see. So this is one of my better days in colposcopy clinic, so you can definitely see it's me, and I think you'd agree that's better than normal, isn't it? Oh, come on, guys, give me a bit more than that. Yeah, okay. So I've named and shamed myself. It gives you just a little bit more than that. So in this day and age, we can do a little bit better. So we've reviewed her cytology, and then we would actually, in our MDT, we would actually play back her colposcopy. So this was this lady's actual colposcopy. That was her DISIS map. I thought it was CIN2, quite a large area, and biopsies were taken from those points. Histology was looked at. Again, I get really confused, but I think it's a little bit dark around somewhere there than it should be. So that was thought to be CIN2 on histology. So our MDT annotation is as follows. The reasons that she was discussed was with moderate cytology, colposcopy CIN2. We thought it was quite a large lesion in the colposcopy that was seen, no evidence of invasion on histology, and suitable to offer conservative management if that was her wishes. She then gets a further letter, so you can see, and I think one of the questions I might get is, well, aren't you spending all your time writing letters? So she gets, again, another letter saying she's suitable for conservative management, but if she wishes to discuss it further, or alternatively has decided to revert to wanting to be treated, she can be treated at that point in time. If not, then she can go on to have follow-up appropriately in 6 months' time. So she decides to go for conservative follow-up. There's no change in her personal circumstances. She continues to use the pill. She continues to be a non-smoker. Cytology is repeated prior to colposcopy, and then her colposcopy again is repeated, which this time suggests a smaller lesion with what I thought was a lower grade appearance. So as a consequence, I didn't take biopsies. I repeat that exactly to the patient in question, so she's aware of exactly what we've done. And then her smear test comes back again, even though I think things have got better. Her smear test again comes back showing that she's got moderate dyskaryosis. So I once again tell her that she's going to go to the MDT. So the first thing we do, and that's the benefit of longitudinal tracking, by whichever digital system that you might choose, you've got the ability to compare one against the other. So we tend to play both of them back sort of right on from each other. So the first thing you do is you look back at March. And then you lead into September. And that's her map from September. So I think you'll agree colposcopically, it looked a lot better than when we first looked at it, and her map would certainly concur with that. And then you have the nice ability to compare one map against the other map. So fairly good regression rate. Her cytology also is looked at again, so we look at it in the correct order in which it's done clinically, and I think you'll agree that although there appears to have been some improvement in her cytology, there are still some areas of higher grade abnormal cytological cells, backed up in that slide as well. So again, her MDT annotation reflects entirely that. There was no change to the cytology, a reduction in the size of the lesion was noted, continued to offer conservative management, but here's the important bit. If, consider repeat biopsies and excision, especially if dyskaryosis persists in the future. So that was what was sent to the patient. Again, she gets a letter informing her of that afterwards, so crystal clear exactly what the plan is, both for you in the notes and also for the patient. I was hoping very much that she was going to come earlier this week and I was going to show the examination and sort of show you what I thought. Obviously, I might not have had the cytology report, but unfortunately she rescheduled to mid-May, so I wasn't actually able to show you what happened to her so far. So some questions come up from that, and we've touched on some of them already. So should these patients be discussed at every MDT? We didn't actually put that in the good practice guidance. We left it to unit preference. Me personally, I think you probably should. I think it's a very small number of patients, potentially, if they do go on to have a cancer diagnosed a number of years down the line, I just think it makes more sense to put a small number of patients each visit through your MDT. Return to the community. Now that's a bit tricky. So if their colposcopy goes back to normal and their cytology goes back to normal, do you just discharge them back to 3 or 5 yearly recall, or do you actually do a 6 months MDT approved test of cure type thing? Because you've taken biopsies, you've got high grade CIN confirmed, so actually realistically if you discharge them straight back to 3 or 5 years, they may be getting less follow-up than somebody who just had CIN1 untreated. So I must admit, my own unit, we do the 6 months MDT approved HPV test in the community 6 months after we've discharged them. I think conservative management is hugely influenced by the colposcopist, massively influenced. You can be in clinic and you could be, and I'll be devil's advocate, you could be CIN2, pre-malignant, might go on towards cancer. Well, I probably wouldn't if I was you. You can really, really sell it one way or the other. So I think influenced by the colposcopist and how that's put across is actually subject to huge bias, and I'm not really quite sure how you best get around that. I think you have a moral and an ethical obligation as the colposcopist to give your true opinion as to what's there. Should you do a separate consent form for somebody that you're managing conservatively? I don't know. We certainly don't do that at present, but that was one thing that was discussed at our meeting. Audit, we tried to think about doing it as a region-wide audit, but with the changes in PHE and things, that might not be particularly easy to do. So what I'm about to do in the next few weeks is write to all our units and say, following on our meeting, we'd like each unit to just suggest that you audited those cases on an individual unit basis. And I think it's quite clear from the national study that most people would actually value doing some form of nationalised work regarding a multi-centre research study. And the role of digital colposcopy, I'm very, very comfortable with the system that we've got that allows us to actually longitudinally track these patients. I think it's a great system, and personally I'd feel a lot less comfortable without it. I don't necessarily think it has to be DISIS, but I think you do have to have some more credible way than my rubbish diagram with just 2 crosses saying CIN2. The ability for all the colposcopists in the MDT to effectively look at the whole colposcopy examination, I think, is paramount to managing these patients. So it's all actually, I think, to sort of personalise it a bit, it's all actually about change, and it's about making things better. We have a fantastic cervical screening programme. It is really, really good, and it's very, very humbling, especially when you hear talks yesterday about the state of cervical disease in the third world, that we remember that. So most of the husbands in the room, I think, will be like me. I've got 2 very expensive women in my life. The one on the left is slightly older, and I used to say is slightly more expensive, but the one on the right is becoming a teenager, so that graph is beginning to cross where I'm not quite so sure which one is more expensive. Now, the slightly older one on the left, without giving too much time away, she's about to change from 3 yearly screening to 5 yearly screening. She has been served extremely well by the cervical screening programme. She thankfully has never had an abnormal test, but she has fully engaged with it, and if she had have had an abnormal test, I'm sure it would have served her very well. My daughter, on the other hand, 12 years old, she's about to effectively enter the cervical screening programme. She has her first dose of Gardasil, and she, I think, would like to think that in 10 years' time, when she potentially goes for screening and that potentially might be abnormal, things will change. She's had her Gardasil, she's had her vaccination. She might, if she does get an abnormal test, will that screening test, will that be primary HPV screening? And then will she get additional biomarkers on top of that, P16s, E6s, etc.? And then actually when she ends up in colposcopy, will we by then be doing it differently? Will we conservatively manage people? Will we minimally excise people? So the world is changing, and I think one of the important things about meetings like this is that we discuss change, and change drives things forward, and it's quite clear that there's a groundswell feeling that maybe we can change some aspects of how we manage high-grade disease in women who are desirous of fertility. I think my own personal view, for what it's worth, is that's probably the population it's suitable for. The 48-year-old woman who comes to your clinic with moderate dyskaryosis, I just see and treat those people. Who's completed their family, why would you do anything different to those women? So I think it is for a small group of women, but I think it's a very important group of women. So thank you very much, and I'm happy to take some questions.